Cool. So hi everyone, and thank you for joining today. I'm Cameron Booth, and I'm joined by my colleague Claire Temple. And the session today is using social media to support childhood immunisations in general practice. It's about reaching the right families with the right messages at the right time. I also appreciate how busy general practice and PCNs and ICB teams are. So I want to be really clear about the purpose of this session from the start. Today is not about teaching you how to use Facebook or Instagram. It's also not about turning practices into marketing organisations, and it's not about arguing with people online. This session is about trust, it's about confidence, and it's about how communication now shapes prevention outcomes in a post-COVID environment. Cool. So we're going to focus on childhood immunisations, but the principles we discuss will apply much more broadly across prevention, including screening and health checks. And my aim is that you leave this session with a clearer understanding of why communication feels harder than it used to, what actually works in practice, and how social media fits into the wider system rather than sitting awkwardly alongside it. One of the most important points I want to make early on in this session is for most families, access is not the main barrier to childhood immunisations. Appointments exist and clinics exist. Nursing teams are delivering excellent care. What's changed is confidence. Across many practices, what we now see far more often than outright refusal is hesitation. Parents delaying, parents missing appointments, or parents saying they'll come back later, but later never quite arrives. And at the same time, families are exposed to a constant stream of health information online. Some of it's accurate, some of it's misleading, much of it is contradictory, and that environment makes decision making harder, not easier. So when we talk about uptake, we need to recognise that confidence, not access, is now one of the biggest determinants of whether families engage. I'm just going to hand over to Claire.
Thanks very much, Cameron. So yeah, as we said, COVID fundamentally changed how people relate to health information. During the pandemic, families were exposed to an unprecedented volume of messaging, guidance changed frequently, and messages were delivered across TV, radio, social media, and informal networks. And for some people, that increased engagement with health information, but for others, it created confusion and anxiety. So what we see now is not, as Cameron says, hostility towards healthcare professionals. It's questioning and it's caution and it's a desire for reassurance. And these changes show up in consultations, at reception desks, and in those missed appointments. And the key point is that this is a structural change in behaviour, and it's never going to revert back to how things were before COVID. So general practice remains one of the most trusted parts of the NHS, and that is an incredibly important foundation. The challenge is, though, that trust alone is no longer enough. Visibility now matters. And parents form opinions and anxieties long before a text or a letter from their practice arrives. And by the time they speak to a clinician, they may already feel uncertain. So when trusted voices are quiet in digital spaces, other voices come and fill the gaps. And these voices are often confident, emotive, and persistent, even when they may be wrong. But this means that by the time families engage with the practice, conversations are already harder than they need to be.
Claire, I don't know if it's the same for other people, but I'm having a slight issue with the audio. It seems to sort of fade in and out a little bit.
Okay.
I don't know if other people have got the same. It's only slight, but it is a little bit difficult to hear.
That's fine. I'll move my mic closer and hopefully
that
helps.
better. That's better.
Fabulous. Okay, sorry about that. So childhood immunisation, the programmes are often experienced by families as individual decisions, but clinically and operationally, they are collective. So herd immunity depends on that population level confidence and participation. But when uptake drops, the impact is not evenly distributed. It affects the most vulnerable, including newborns and your immunocompromised patients. And that's why communication matters at a community level, not just in individual consultations. So, social norms, expectations, and what feels routine all influence whether families engage. So, social media should never be seen as a replacement for the existing engagement methods that you have in practice. But it does play a big role. But it does not replace those calls and recalls. It doesn't replace those text message reminders. It doesn't replace those conversations with clinicians or reception teams. What it does is reinforce those messages and reassures parents before they receive an invite. And when we see families seeing consistent information across multiple channels, confidence increases, messages feel more credible and more familiar. And that's where social media adds value without adding any clinical risk. So one of the most underappreciated aspects of communication is repetition. So repetition is not nagging, it's reassurance. So parents often need to see a message several times before they feel comfortable acting on it. And social media provides a low pressure way for practices to stay visible and reinforce key messages without that direct contact. So this background reassurance plays a very significant role in reducing anxiety and normalising attendance. So social media, again, is particularly effective for reaching those families who may not engage well with traditional communication. These aren't disengaged families. They are often families juggling work, childcare, and multiple demands in life. But for these cohorts, informal, visible communication can be more effective than formal letters. And I'm going to pass back to Cameron now. Thanks.
Thanks, Claire. So most parents are already spending time on social media every day. Messages from a local GP practice feel very different to national campaigns or anonymous sources. They feel relevant, familiar, and grounded in real services. This familiarity builds trust over time. So just to show you some of the reach that practices are having in local communities, here are some stats, some headline stats taken from the social media managed service that we run for hundreds of practices across the country. So you can see every month we're reaching millions of people, and we've got lots of followers across the practice network, and lots of people liking, commenting and sharing the posts as well. Some individual practice accounts that we manage reach their patients literally hundreds of thousands of times per month, including Bay Medical Group in Morecambe from the slide earlier on. They reach their 7,000 patient followers about 300,000 times per month on Facebook alone. So really effective in getting lots of important messages out far and wide in their community, and it really does work if done properly. One additional point that is really important here, especially for confidence within practice teams, is where information comes from. Trust is not just about tone, it's also about credibility and consistency. Practices do not need to create new explanations or reinvent health messaging from scratch. Some of the most effective and safest social media content is simply sharing or reframing or signposting to validated, quality, approved health information from trusted national sources. That might include content from NHS UK, UK HSA, or other nationally recognised public health bodies, including maybe your ICB teams. Using these sources does a few important things. First, it reassures patients and parents that the information is evidence-based and nationally endorsed, not just an individual opinion. Second, it protects practices and staff. Sharing approved content reduces risk and removes pressure on individuals to explain everything themselves. And third, it supports consistency, because when parents see the same messages reflected across national and local channels, which they will be doing, confidence increases and uncertainty reduces. Importantly, this does not mean copying and pasting long clinical guidance into a Facebook post. It means using short, accessible summaries and linking out to trusted sources for anyone who wants more detail, or just resharing existing social media campaigns. And this fits perfectly with the principle of trust over debate. You're not arguing, you're not correcting people publicly. You're calmly reinforcing reliable information from sources families already recognise, and that combination of a local trusted voice and nationally validated information is one of the most effective ways to build confidence without creating conflict. In terms of what to avoid, this slide is not about criticism, it's about realism, because a very common instinct, especially among clinicians, is to want to correct misinformation wherever it appears. That instinct comes from a good place, but on social media, it often backfires because long clinical explanations tend to overwhelm rather than reassure. And public back and forth can unintentionally legitimize misinformation by giving it attention. We've seen many examples where a single defensive reply causes a post to take on a life of its own, pulling the practice into a conversation it never intended to have. And the practices that do this well set clear boundaries. They decide in advance what they will respond to, what they'll redirect offline, and what they'll not engage with publicly. And that clarity protects staff confidence and keeps the tone calm and professional. Also importantly, comment management is one of the biggest perceived risks of social media, but in practice, it's far more manageable than people expect. Again, we manage over 800 social media channels for practices across the country. We've done it for over 8 years, and see some of the areas, some practices that say we've got real keyboard warriors in our population, the patient don't particularly like us, or they're in a really deprived area. We're yet to see a practice be overwhelmed with negativity if managed properly. And you can also sort of change the settings on social media to remove the ability of patients to do certain things. Most routine immunisation posts receive little or no negative engagement at all, but when comments do appear, the presence of a clear moderation policy makes an enormous difference. Good practice here includes making it clear that clinical questions cannot be answered publicly. So think about pinning a welcome post to the top of your page as a disclaimer, and that's going to cover you in many respects. Redirect individuals to contact the practice directly for individual queries. And remove comments, so hide comments that breach policy without engaging emotionally. So what's often overlooked is that the silent audience matters more than the commenter, because hundreds or thousands of parents may read a post or comment without interacting, and they'll take confidence from seeing that the practice is present, calm and professional. I'm just going to hand back to Claire.
Thanks, Cameron. There's a question in the chat, but we'll get onto that afterwards. So this next information is really important because it moves us from principle into practice. So up to this point, we've talked a lot about trust, visibility, and reassurance. And this example shows what that looks like when it's applied to a real prevention programme. So recently we supported a 12-week NHS Health Check pilot working with GP practices in areas of high inequality. And the challenge was a familiar one. So these are patients who had already been invited through standard routes and hadn't responded. And rather than simply repeating the same approach, the programme focused on the communication design. So this meant using data to identify the right cohorts and then coordinating those text message invitations and tailoring the messages to each different cohort, adding in some short AI video messages, reinforcing those invites through calm, consistent social media posts from the practices themselves. The important point here is that nothing about the clinical delivery changed. Practices still delivered the health checks on site, as they always do, but what changed was the visibility and the confidence, and that patients saw the messages more than once. They encountered it in different formats. It was tailored towards their particular cohort, and they saw it coming from a trusted local source, not just from an automated system. And the result was a clear increase in the uptake during the pilot period, and particularly among patients who don't usually engage with prevention activity. So equality was important, and that impacted the workload, but by automating parts of the communication and providing shared progress dashboards, practices reported a meaningful reduction in that admin time as well. So this matters because it shows that better communication doesn't mean more work. When it's planned and coordinated, it actually reduces pressure on practice teams. And the reason that this example is relevant to the childhood immunisations that we're talking about is that the same principles apply. Both rely on trust, repetition, visibility, and confidence at a population level. So the NHS Health Checks pilot is not only relevant because it was about health checks, but it's relevant because how we approach the communication. So if you strip it all back, the model is very simple. So first it starts with data. As I said, identifying the cohorts and knowing who is due, who is overdue, which groups are least likely to respond to standard invitations. And that's exactly the same challenge we face with childhood IMS. So second, it uses multiple channels in a coordinated way. So instead of relying on a single letter or text, patients encounter the message in different formats. So a direct invite, a short accessible explanation, reinforcement through social media and from trusted local sources. And this matters because people rarely act on the first message they see. And then third, it relies on repetition without pressure. So seeing the same calm message more than once builds familiarity. And familiarity reduces anxiety. And then reduced anxiety increases uptake. So this is particularly important for childhood immunisations where hesitation is far more common than refusal. And lastly, it shifts confidence earlier in the journey. So by the time patients are contacted by the practice, they already understand why the appointment matters, what to expect, and that this is routine and it's supported from the practice, and that the changes, it changes the quality of the conversations that you have in practices. It reduces the friction for those practice teams. And when communication is planned and coordinated, fewer of those appointments are missed, fewer follow-up calls are needed, and fewer basic questions reach reception. So this is not about adding another layer of work. It's about making your existing work easier and more effective for you. And output. So success is quieter than people expect. So you may not see a huge jump in numbers, but what you will see is better informed parents, more confident conversations, and fewer basic queries coming through. So everything we've discussed today applies beyond childhood immunisations, as we just said. So prevention programmes face the same challenges: low response rates, uneven engagement, and higher drop-off in more deprived populations. But what we consistently see when communication is planned, reassuring, visible across channels, and uptake improves and the workload reduces. So social media plays a supporting role by making all of that information visible and familiar rather than abstract or administrative. And I'll pass back over to Cameron. Thank you.
Thanks, Claire. Just quickly want to address the question around how stopping patients commenting. So we recommend, so basically what we always do when we set up social media in practice is you turn off, as a rule of thumb, the ability to, in the settings, turn off the ability for patients to be able to post on your page or to direct message you, tag you in personal posts, or write reviews on social media. There's no direct way to turn comments off as such. There are some workarounds that you can do. You can turn comments off for individual posts, especially if you think that they're going to be potentially triggering. Like if you put a post on about the telephone lines being down, for example, you can switch those comments off on those particular posts. But generally, we advise anyway, leaving comments on. It's the only way that people will be able to engage with you on social media. It'll help you create a social media presence that people will want to actually follow. It doesn't really feel very authentic or open when there's a practice page without many comments or the ability to comment. So people generally don't like that. Again, we manage so many pages, we've done it for so long. You'll probably be surprised that people don't generally comment in the way that you think. You might have a batch of a couple of weeks at some point because of some issues going on in the practice where you get a few more comments, but if managed properly, it shouldn't be a problem. You can hide comments in a way that the patient will still see their comment, but the public won't. So it's like a non-combative approach to removing negativity. But we do recommend leaving the comments on, and they give you so many opportunities to answer questions that otherwise you might receive phone calls about, and just in general develop a much more successful social media. I'll just pop my email in the chat if you want to pick it up separately. So why this is hard alone. So most practices already understand the value of good communication. The barrier is not insight, it's capacity. And social media does require planning, consistency, awareness of priorities, confidence in tone and boundaries. And when it's added on top of everything else, it quickly becomes reactive or drops down the priority list, especially when managing things like comments. It's not a failure of intent, it's simply a system and capacity constraint. So that's where scale matters. And we've created the social media managed service to bridge the gap. So for over 8 years, we've been supporting hundreds of practices across the country on social media, which allows us to see clear patterns, what works, what doesn't work, how to manage the pages effectively. And this basically removes the burden of planning and risk management and creating content from already stretched teams. It ensures that communication aligns with clinical priorities rather than reacting to issues as they arise. We've got the SMMS at a cost of £50 plus VAT per month for a fully managed service, including managing your Google reviews. If you've not had a look at those, really recommend doing so now that the NHS reviews service has been decommissioned. We also manage your comments, design posts, and much more. If you're interested in a free month trial, no strings attached, just drop me an email at cameron@redmorehealth.co.uk. I've just popped my email in the chat. So I also just want to talk about using AI avatars to boost your communications efforts. So before I show the example, it's worth quickly explaining what we mean by AI avatars. In this context, an AI avatar is a short video that looks and sounds like a real named GP or clinician delivering a pre-agreed clinically appropriate message in a calm and reassuring way. So for prevention programs like childhood immunisations, practices often need to explain the same things to large numbers of patients. We also know that short video messages are much easier for people to engage with than long texts or letters. And the clinician just needs to create their avatar once, and then it can be used to create unlimited video content that looks and sounds just like them without needing to sit down and record messages each week. And that's why AI avatars fit very naturally alongside everything that we've talked about today around trust, visibility, familiarity, and confidence. I'll just play the video so you can see what we mean. One of the biggest challenges with childhood immunisations isn't access to information. Again, it's who that information comes from. So parents don't just want facts, they want reassurance from someone they recognise and trust, which is generally the doctor or clinicians. And AI avatars allow practices to deliver that reassurance consistently without adding to workload. Practices can create videos to explain, for example, why vaccines are recommended, what the data actually shows, what parents usually worry about, and how to book an appointment. And the avatar acts as the local voice, reinforcing nationally validated information in a way that feels personal and human. You can also obviously use these avatars across the full communication journey, not just on social media in isolation. For example, a parent might see a short immunisation video on Facebook or Instagram, later receive an SMS invitation linking to the same video, and then book knowing what to expect. And that consistency matters. It reduces cognitive load. Parents aren't being asked to start from scratch each time. And from a practice perspective, this also reduces pressure on staff. Instead of reception teams answering the same safety questions repeatedly, patients arrived better informed and more confident. We've seen this approach work particularly well when videos explain common myths and facts, what side effects are normal, why herd immunity matters for vulnerable children. And because the video is calm, short, and delivered by a trusted GP voice, it reassures without feeling defensive or preachy. And crucially, once created, these videos can be reused year after year across different cohorts and adapted to other prevention programs like screening or health checks. So this isn't just a technical add-on, it's a scalable way to build trust, support uptake, and protect practice capacity. And when you combine trusted local voices, validated national information, and consistency, delivery across the channels, you'll stop chasing engagement and start quietly improving outcomes. And really importantly as well, these videos can be translated into foreign languages so the clinicians can actually speak directly to hard to reach groups of your patient populations in their native tongue. So if you've got many different cohorts that don't speak English as your first language, this can be particularly effective. Think about also sending text messages to those people with these videos. And this technique is really already proving highly effective. If your clinicians don't want to have an avatar of them, there are plenty of generic ones to use as well. We do run an AI avatar managed service alongside our SMMS program, which also costs just £50 plus VAT per month. So please let me know if you're interested or want to see some more examples. So if there's one message to take away, it's this. Childhood immunisations uptake today is shaped as much by communication as by access. Visibility, consistency and reassurance matter, and social media, used well, supports prevention without increasing pressure on practice teams. So I'm just going to pause there and open up to questions. We'll turn on your microphones and cameras. And if you want to continue the conversation afterwards, we're always happy to talk through what supported social media could look like for your practice, or in general, if you've got any wider questions or concerns about what we've talked about today.